Well, recent years, the last 10 years, but specifically the last 3 years, we have learned so much about the correlation between cardiovascular disease and renal disease in patients with type 2 diabetes. We have for years been very glucocentric. We have looked at body weight decrease, but now we have a lot of evidence that our glucose-lowering drugs also have beneficial effects for our patients with cardiovascular disease and very much indeed with renal disease as well. So it has taught us that treating type 2 diabetes is complicated. We have to collaborate between different specialties, and together we can really make a huge difference for our patients with diabetes. Well, it has actually had a major impact because last year, actually at the EASD, we had new guidelines. I'm a big fan of those guidelines because they're very innovative, they're very evidence-based, and they're progressive. And even within each class, they actually discuss the different trade or the compounds to be used. I think our challenge right now is to how to get these guidelines implemented for all patients with type 2 diabetes. So not only the patients that see doctors, that go to conferences, but actually every patient with type 2 diabetes should benefit from the modern diabetes treatment. That's the challenge right now. The short answer is yes. Very much indeed. I've been doing research within the incretin field for more than 20 years, and I've also really taken the SGLT2 inhibitors to me. Now we have so many trials, almost 20 trials published looking at cardiovascular disease and patients with type 2 diabetes. With a position statement or guideline from the ADA and the EASD and the recent ESC guidelines, we really have the knowledge, we have the evidence to treat our patients with either SGLT2 or GLP-1 if they have cardiovascular disease. I usually teach my colleagues and younger doctors that if you see a patient who has cardiovascular disease and who is not on an SGLT2 inhibitor or a GLP-1, you really have to wonder why and do your best to initiate this treatment because it's actually saving lives and it's really improving their life story of their diabetes. So yes, indeed, we should. Well, I've been in the field of GLP-1 for more than 20 years, and it's actually a question that I've had very often, is the injection a barrier? And to my opinion, the barrier with the needle, as we say, is by the doctor, because we have good injectables. We now even have them as once weekly injectables, and they're really, really efficacious. I'm from Denmark. I've had semaglutide once weekly on the market for more than a year now. And the patients are so motivated because they have a glucose-lowering drug that even is combined with body weight decrease, beneficial effects on blood pressure. And then I can tell them, and they have heard, that it's also good to prevent cardiovascular disease. Of course, in general, it is a benefit if you can just take another tablet. And I'm indeed looking forward for the oral semaglutide to reach the markets because just delivering a peptide through the oral route is incredible, and it's good. It's good that it will reach the market. I'm looking forward to treat patients. I've been in some of the trials with oral semaglutide. It's interesting. Also, the whole concept about GLP-1 being delivered where it was actually meant to be, down in the gastrointestinal tract, is really, really interesting. So I think it's really good to have those two different mode of administration, and I'm looking forward to the future. I always enjoy being at the EASD. I was part of the organizing committee from the scientific point, and it's always great to see the titles of the symposiums being up there and the composition of the different symposiums and oral presentations. So far, the venue is really great. You get together with all your colleagues, and from a scientific point of view, I just went and saw some of the post hoc analysis on the huge cardiovascular outcome trials, looking specifically into changing the life story of diabetic nephropathy in patients with type 2 diabetes. So I'm impressed about all the results we see specifically with with the GLP-1 receptor agonists and the SGLT2s. And I'm really looking forward to the rest of this conference and all the next ones to come, because we still have so much more to do. And right now our focus is how do we really get this collaboration with the cardiologists, the nephrologists and the endocrinologists to play in the everyday life for our patients with diabetes.